This week we're going to be looking at the shoulder and the scapula. You'll see the shoulders fairly frequently out at the clinical sites, but the scapula not so much. This is typically one that you're going to have to do a simulation on toward the end of your program, but maybe you'll get lucky and see some. Um, this this was pretty creepy. It looks like the person's going to grow some wings on them, but apparently it's a syndrome called winged scapula, and it happens when the serratus anterior muscle, which attaches to the anterior portion of the scapula to the ribs, and that's affected by the thoracic nerve. If there's an injury to that nerve or to that muscle, it causes the scapulas to um, move out away from the ribs, and it's just incredible. It takes up to 18 months to a physical therapy to get that uh, back to normal where they should be up against the ribs and the and the thorax. Okay, so that's an interesting way to start with that interesting picture. So I'm not going to read this stuff to you. I want you guys to be able to go through these. I'm just going to give you an overview of everything. So the shoulder girdle basically is the clavicle and the scapula, and included in the shoulder views are the head of the humerus, the proximal portion of the humerus, and the manubrium at the of the sternum where the clavicle attaches. Next, we have the anatomy of the scapula. The scapula is a flat triangular shaped bone, and I just want to point out the angles that we have. When you're evaluating your images out for your competencies, what I want to hear is that you know all the angles, you know all the borders, you know which surfaces are anterior and posterior, and there's a lot of little parts and how they work together. So you'll have the inferior angle down here, the superior angle up here, and the glenoid fossa is part of the head of the scapula, and it's the also the lateral angle of the scapula. The lateral angle of the scapula is formed by where the superior and lateral borders of the bone come together, and then it makes the cavity that articulates with the head of the humerus. From the lateral side, you can see the glenoid fossa here, and you can see the spine of the scapula and the coracoid process. Remember, I told you coracoid, you can remember because clavicle and coracoid both have C in them, as opposed to the elbow that has a coronoid. The noid is in the elbow. So coracoid process at the scapula. And another thing, because the shoulder, even though the humerus is not considered part of the shoulder, it does articulate. So you have a lot of the anatomy on the proximal humerus that you're going to need to know. So, like the femur, you have a greater and lesser, where you have a greater and lesser trochanter. The tubercles on the humerus are smaller and a little closer together. So if you see the greater tubercle, a lot of times you don't see the lesser tubercle in the same view. That's why we'll do two views so we can see it in a different projection. We'll see the lesser in one and the greater one in the other. So shoulder views routine are internal and external rotation, Y view, and the axillary view. Those are the typical ones. You also would do a Grashy view or bicipital groove view that are not as quite as common. If you're in orthopedics, you probably would do these quite often, but for general purposes, you'll do internal, external, and probably a Y, and occasionally the axillary view. Patient prep is just like anything, waist up off. You don't want any jewelry or bras or straps or buttons, hooks, anything like that in the area. Shield all your patients for this view. There's no reason not to. Suspend respiration, always just hold your breath. Um, Breathing technique on the transthoracic lateral view, and it gives you a much better image of seeing the head of the humerus and the top of the scapula from through the lung field. All of these views are going to be 40-inch SID. Most of them are going to be 10 by 12 image receptor, and all of them will be small focal spot size. Your collimation and your IR orientation will depend on the view, because some of them you'll do crosswise and some of them, like the Y view, you might do lengthwise. So it just depends. KVP and mass will vary, of course, depending on where you are and the type of equipment you have, but use Jeff and Jocelyn's techniques for your practicals. That's probably your best bet. Typically, all these exams are done upright. Unless you have a trauma patient, then it might be cross table, or it might be supine. Patient might be supine. And as far as your collimation, just remember, as always, your bones are typically not outside of your skin. So if you just keep your collimation within an inch or so of the skin line, you should be in pretty good shape for not having your collimation open too wide. So internal and external rotations vary just a little bit. Your position for your patient's pretty much the same. And it says you want the scapula parallel with the plane of the image receptor. So you're going to you're going to rotate the patient just a little bit toward that affected shoulder. So the difference will be on an internal rotation, you're going to rest the back of your hand on your hips. Your hand will be rotated internally a little bit. And you want to look at the humeral epicondyles. They are perpendicular to the image receptor. That's going to be your best way to make sure that you have the proper position for the internal rotation. And external rotation, your hand is in the anatomical position, facing out, supinated, and your epicondyles are going to be parallel to the image receptor. This is what your patient's going to look like. Look at her elbow and see which position this is. So internal rotation, look, her elbow is perpendicular to the image receptor. A lot of places are going to want you to include this sternoclavicular joint medially, but check with your sites just to be sure which way they want you to do it. Some say 2/3 of the clavicle to be included on the view, and some want all the way to the manubrium. So do whatever it is that they say at your site. Now, as far as when you're looking at an image to evaluate it, you want to look at the head of the humerus. Students last year were saying that the head of the humerus on an internal rotation looks like an ice cream cone. And both of those start with I, so that might be a way to help you when you're evaluating an image to look at that and see if it looks like an ice cream cone. It's probably internal rotation. And you should be able to see the lesser tubercle in this particular view. On the external rotation, they said that the head of the humerus now looks like a puppy, a little puppy. I'm not sure where that came from, but I guess if you've got a vivid imagination, you might be able to see it. Typically, you're going to see the greater tubercle, and you can see the lesser tubercle is more hidden on this particular view, but the greater tubercle should be out laterally with the external rotation. And once again, look at her elbow. You can see that it's parallel now with the image receptor. In the neutral position, these are typically for trauma patients. You just want to leave them the way they are. A lot of times they can't move their arm or they can't move their hand, or they're going to be supine. Just leave them the way they are, and the image comes out the way that it comes out. So if it's a trauma, you don't want to move your patient. Otherwise, the view is pretty much the same. You center 1 inch below the coracoid process, and if that's where you're centering, you open your collimation to 10 by 12 if you need to go over to the sternum. Otherwise, collimate so you're an inch outside of the edges of the skin. The Grashy view is an oblique view. A lot of times when you're doing rib studies, you can see a really great Grashy view when you're doing LPO or RPO position. It looks the position is very, very similar. So with the Grashy view, your central ray is perpendicular and you want to center right about at the glenoid cavity. So that is 2 inches medial and 2 inches inferior to the superolateral border of the shoulder. So wherever 2 inches from the edge of your skin, from above the shoulder and next to the top of the humerus, will help you find your centering spot for your Grashy. You can use an 8x10 cassette or image receptor for this one because it's a much smaller area. You can collimate tighter. So the side that's against the image receptor is the one that you're focusing on, not the side that's up. This is what your patient's going to look like. It's a nice open glenohumeral joint. Infero-superior axial projection. This one, the students are pretty much intimidated by because it takes a little maneuvering of the tube and the image receptor to make sure you have the right angles and you have the patient in the right position, you have the cassette in the right place. So it takes a lot of work to get this positioned properly. So you want to be sure in lab to practice quite a lot. You have to make sure your image receptor and your tube or collimation box are parallel to each other, or you will get some elongation or foreshortening of the part, or you might not even get the joint on the image. It might be projected off the edge of the image receptor, depending on your angle and your patient position and how far you have the cassette pushed in toward the patient's neck. It's worth practicing and figuring out how to get that tube moved into the right place before you have your practical exams, because you may draw this one, and I know that last semester people were not very happy about getting this one. So your central ray is horizontal and you're going to center right directly through the axilla, through the armpit. And so you can see where you really need to have the cassette pushed over far enough into the neck and the head's turned away. In this particular view, the hand is supinated. Some of the views, the hand will be prone, turned over. So it just depends on what the radiologists prefer, I think. I haven't ever seen anybody do it with the hand supinated, but like I said, every radiologist is different, so we'll go by what their protocols are. This is what your image is going to look like. And I love this picture because it has a really good representation of the bones and the x-ray. So everything's labeled really, really well. So when we look these over for your competencies, we're going to talk about specifically what the anatomy is and where it is and what you're seeing. This is another interesting view, and it has to do with whether the hand is prone, so your hand is turned toward the floor, so your elbow epicondyles are at a 45-degree angle from with the floor, and it looks just a little bit different.